Hi. You're good.
I'm sorry, say that again.
Good recording in progress.
Okay, I guess that means it's good. Well, nice to be back with you all again. I did hang out for Asbel's conversation. It was a very good one, and it has been very similar to our experience. The one thing that I really want to reemphasize, something he said, many things that he said, but relationship, absolutely. I can share with you that the network chiefs that we have negotiated our contracts with, we've developed a great relationship. In fact, one of them recently had a baby, and we have dialogue offline, not even talking about the network agreement or the contract for the services that we're providing, just to check with kids and grandparents. And really building that relationship is hugely important, and that helps a lot. And the second is never, ever, ever be the one to first offer the price. I had that recent example. I had that example recently where, somebody said, well, what should we pay you? And we said, I don't know. What would you like to offer? And to be quite frank, their offer was a different decimal point to the better than what we were thinking we would get paid. So often our perception of value to the person signing the check is different when you're signing the check. So if, to the extent that you can, do not be the one to offer the price, because you'll be surprised typically. Now, know your cost, as Asbel said, and as we spent the morning talking about, so you know what you can't accept, but don't be surprised if they come back with a much different rate than what you were thinking, to the good, because that does help. All right, so we're going to try and walk through how you should determine your fees. I will share with you that this is a very political decision. This is a very logical decision at times as well, but the two are linked. In order to win the political battle, you need to be able to show what you need to charge in order to collect the money that you need to either minimize cost offset from the public, whatever form that's going to take, sales tax, property tax, whatever, and to explain it, as Tim indicated during the break, when somebody called before the break, when somebody calls to complain about the bill, you need to be able to explain how the charges were derived, because it does make a huge difference. So for the next 30 minutes, hopefully 20, because we'll leave some time for Q&A, we're going to discuss system costs. We did a lot of that already, but we're going to summarize just a little bit of that. We're going to talk about the issues that surround commercial insurance. And it's a huge issue because commercial insurers, unless you're in Colorado, choose to pay whatever they want to pay. So you guys have addressed that to some extent with some of your balanced billing legislation. So kudos on that. And determine how you're going to come up with your ambulance fees by doing a bit of a comparison and making sure that your fees are going to cover your costs, which is our goal. So I just want to make sure that understand the limitations of the fee increase. Remember this, we're going to talk about the 10-to-1 ratio here in just a moment, and really it's more like 100-to-1. Just to put this into context, for those who don't know, our public utility model system here at MedStar, which the official name is the Metropolitan Area EMS Authority, but that's way too many letters to put on the side of an ambulance. So the trade name for 38 years now has been MedStar, just because it's easier. As you can see, some statistics there, really busy system. The thing that I want to highlight is currently no tax subsidy. And we'll explain how we got there in just a minute with that external oversight. So financing your EMS system is really a public policy decision, and different communities are going to fund it, or going to do it a different way. A funny story to show the context here. The current Fort Worth city manager, who came here in 2013, 2014, was the former deputy county manager for Wake County, North Carolina. And part of his deputy county administrator duties, the department that was assigned to him, was Wake County EMS. So he and the directors, because there were a couple during his tenure for Wake County, worked a lot together. And when the city manager came here, we did an introductory meeting. He came to the facility and we explained how the system works. And when we got to the point of explaining that we do not currently receive any tax subsidy, he was dumbfounded, picked up his phone and texted his friend, who was the director / medical director at Wake County EMS, and the text message went something like this: what the hell? I'm sitting with the folks from MedStar, and they're running a busier system than we had, with more sophistication, more this, more that, and we don't write them a check. I was writing you a check for millions of dollars every year. How can they run their system non-subsidized? And I was funding, millions of dollars of your system. And I said, David, seriously, it really comes down to the philosophy of the system. I'm willing to bet that the average bill in Wake County is much different than the average bill here at MedStar. Our average bill at the time was $1,300. And he said, well, you're right, because the average bill in Wake County was about 600. I said, well, there you go. When you underbill, you're going to require public cost offset, Tim, to balance the books. The philosophy here has been, for the last decade, and really for the majority of the time that the public utility model has been in existence, that we want to maximize third-party reimbursement and user fees to not have to use tax dollars to offset the cost of delivering service. Some of the things that go into that cost, we talked again a little bit about this morning, was service delivery, response time expectations. A lot of systems are changing that just based on the economic and clinical models that surround that, response times, clinical levels. We talked about that. Market fees, the whole discussion about balanced billing. There are communities that do not want their residents to get a balanced bill. So they're going to accept whatever insurance pays. So you're sort of at the mercy of whatever the Blues or Aetna, Cigna, Humana, whoever is going to pay, because your policy in your community is that you're not going to balance bill, and that becomes a significant problem. But again, that's a public policy decision that when you say to your elected officials and to your appointed officials, hey, because we don't balance bill, we're going to need to use more tax dollars. Okay. But then that gets into a whole nother discussion. So that's sort of the low fees. And we talked a little bit about that in the morning, but just wanted to bring that back into focus. Now, what we look at here in our system is essentially this chart, and we do it every month. And we essentially say, okay, as you saw this morning, expense per unit hour, expense per response, expense per transport, and try as hard as we can to get our revenue per transport, revenue per unit hour, revenue per response to be above the expense. And that we've been able to do that for the last 10, 11 years, which is why and how we've been able to remain non-subsidized. The other thing to keep in mind, your system design and how the system functions is going to be different whether you're an exclusive provider or whether or not you do things like bill for, treat, no transport. So our system and many systems around that are public utility models, we're an exclusive provider. If there's an ambulance call to be done, emergency, non-emergency, whatever, in our jurisdictional boundary, we have to do it. It's against the law to use a different provider. It's a $500 fine to request an ambulance other than the authority. It's a $500 fine to provide ambulance service unless the authority requested you to do it as part of a mutual aid agreement, whatever. So that becomes a big deal. That's also true for all standbys. So we are the exclusive standby provider. Now we can authorize other agencies to do special event standbys, but only to the extent that we authorize them to do that. The reason that the system fathers and now the member jurisdictions set that up was to minimize the potential need for cost offset. So if we're able to capitalize on all the revenue that is possibly being generated, then it will, in theory and in reality, reduce the potential for that cost offset. One of the things that we do and many systems will do is we offer subscription. It's a membership. I think most people in Colorado and certainly the people in the room know what that is. However, Tim, to your point, I will share with you that one of the things that we released in September, last month, was a subscription plus program. And it includes not only all the things that you typically get in the typical subscription program, but it also includes 2 community paramedic visits anytime, 24 hours a day, 7 days a week, 2 of them a year per household. If you want more than that, that's fine. We're going to bill you $200 each time we come out after 2. But it also includes registration in our CAD, so that in the event that somebody who's that MedStar Saver Plus member calls 911, we're going to co-respond a community paramedic to that 911 call, use our specialized mobile healthcare protocols to try and do everything we can to navigate you to a destination other than an emergency department if it's clinically appropriate to do that. Much like the ET3 model, if you will, but this is available for all of those MedStar Saver Plus subscribers. And we notify your physician, we notify your next of kin or emergency contact in the event of a call and that kind of stuff. So you can do some fancy fee negotiations or fee development, if you will, for these ancillary services. Just so you know, the basic subscription here is $69 per household, regardless of how many people do you have resident relatives that live in your household. The Star Saver Plus membership fee is $350 a year, and it is going like gangbusters. So many people are subscribing for the Star Saver Plus program because they want concierge medicine, the availability to call somebody 24 hours a day, 7 days a week, and have a MedStar paramedic in their house within an hour when they call a 10-digit number. So new parents, grandparents for their kids, people who have medical issues, very popular right now in our community. So we've talked a lot about this, GEMT, provider assessments, we talked about that. Grants, a lot of folks do that. Hospitals. So this is still occurring, although not as much as it used to in the past. Hospitals would offer to be the 911 ambulance provider as a loss leader. They would fund it because it was great market value. And they felt, to some extent, that if they own the ambulance service, they can steer more patients to their hospital. Clearly, that's not the case. Shouldn't be the case, perhaps. But again, sometimes hospitals are willing to fund that more and more today. You're seeing hospitals bailing out of providing ambulance service because it's just economically not sustainable unless they're getting funding from the community, et cetera, et cetera. And these are just, again, some of the ways that you finance the system. Billing. So the realities, and most of you probably know this, is that fees that you charge do not impact Medicare patients, Medicaid patients, or uninsured patients. So we're not going to spend a lot of time on them. Whatever you charge doesn't matter to those patients because generally there's a fixed amount that they're going to pay and you can't balance bill. Everybody knows Medicare, managed Medicare, Medicaid, managed Medicaid. There's no balance billing. Although I will share with you, there's some discussion going on in some states about why can't we balance bill the Medicaid patient? Does the law actually say that? Now you may only collect $1.10 when you balance bill those patients, but without a law that says you actually can't do that, maybe you should be doing that, and let the Medicaid population complain to the legislature that, hey, they're balance billing me $1,200 because Medicaid only paid $210 on my emergency ambulance call. You need to pay more. Maybe we bring them to some of the committee hearings to increase the Medicaid rate. Now, it will impact commercially insured patients. So if you charge a higher rate, there's going to be typically a larger balance bill and you may get additional pushback. Just know that you're going to have this bullet point of explanations about why you're billing what you are for your policymakers, for the patients that call to complain about the fact that, well, the insurance company said they paid $600 and that's all it's worth because that's all the other providers are billing, et cetera, et cetera. And you're going to need some of the data that we're going to talk about here. And as Tim talked about earlier during the break, to really justify that, and I'm sorry, before the break. So payer mix impacts what you're going to bill. So this is our payer mix from 2021 from our audited financial statements. So you can see that Medicare is about 41% of what we bill, and that's Medicare and managed Medicare. Medicaid and managed Medicaid, 17%, commercial 17%, 25% is private pay uninsured. And you can see what we collect per payer. Now, the important thing to notice here is that you really do need to understand that for the Medicare population, you're only going to collect, depending on what you bill, 25% of what you bill. So our collection rate for that particular payer is pretty low. You can see our overall collection rate, 23%. Commercial insurance is only 57%. But again, you need to keep that in context. people get all wrapped around the axle for some reason around this collection percentage. And I will share with you that collection percentage is like monopoly money. It means nothing. Except that people who are doing audits for you need to understand that, you're not going to collect everything what you bill. But I would argue that the thing that we need to be worried about is how much cash are we collecting per billed service, not the collection percentage. We'll talk more about that in just a minute. And you can see how the percent of what we bill that's collected is part of our overall collection. Everybody, and Asbel will probably talk about this later on this afternoon, should have this as one of their dashboards all the time from either their in-house or their contracted billing agency, because this is information that you need to keep abreast of continually. We all know the challenges with commercial insurance, right? So the usual and customary rate, that is the biggest issue. I'm sorry, it's now the second biggest issue. We're going to talk about the big issue here in just a moment. But what they allow, which is typically tied to the usual and customary rate, they decide what the usual and customary rate is going to be. And we're going to talk more about that here in just a minute. Deductibles and co-insurance, because a lot of times people have high deductibles. Who gets the money is a big deal. So in some cases, the insurance company will send the payment to the patient, and then good luck getting it from the patient. So, and that's despite signing an assignment of benefits thing as part of your billing process. Then, of course, medical necessity. Insurers have been pretty liberal recently with medical necessity. However, we're beginning to see that ramp down. You've seen the national stories about Blue Cross Blue Shield denying emergency room payments because they didn't feel that the patient really required an emergency room. They're going to start doing that more and more for ambulance service as well. One of the biggest challenges that we're facing right now, and Asbel mentioned it a little bit during his presentation, is the coverage issue. Believe it or not, there are health plans that are available in Colorado and Texas and every state that does not include emergency ambulance service or ambulance service in general. So you don't even get into a balance billing discussion when you submit the claim to Colorado Blue Cross Blue Shield, and they say, oh, this member has a plan that does not include ambulance service. I have to bill them. And then the member says, holy crap, I didn't know it didn't include ambulance service. They should include ambulance service. Well, if they're not going to cover it, we're not going to pay it. And it gets to be this big discussion because the surprise coverage issue becomes that conversation, even before you get into the discussion of the rates. The determination of usual and customary rate is a huge deal. And insurers will typically say, hey, we're going to use our data. And United Healthcare is now famous for this. They have their own database, and they look at what typically they pay for an ambulance, emergency ambulance call, whatever, and say that's the usual rate. No, it's your usual payment. That has nothing to do with what others are charging, what others are paying. So it becomes a huge deal. And then usually they have some type of allowed amount based on the UCR. I'll give you an example. So Ambetter in our market determined that the usual and customary rate that they should pay as a commercial insurer in our market is the Medicaid rate, because they make the argument, hey, if you're willing to accept the Medicaid rate, that becomes the UCR. And we have this battle with them all the time. That's all Medicaid is going to pay. That's not what the UCR is. And I'll show you how we determine that. But they say, hey, Medicaid rate's Medicaid rate. That's all we're going to pay. So we actually have a commercial payer in our community that is paying the Medicaid rate, and they refuse to pay any more than that. We're going through some legal stuff with them to see if we can have someone convince them that they really can't do that. Deductibles, co-insurance, who gets the money? We mentioned that already. Medical necessity. There you go. I want to remind you of this. So again, our goal is to collect $464, preferably $470. And our collection percentage is 23%. So right off the bat, if you take the 463 and divide it by 0.23, that's going to tell you what typically we need to charge. But as Asbel mentioned, collection percentages are variable. And if you charge more, your collection percentage is going to go down. You charge less, your collection percentage is going to go up. That's really kind of hard. So we do it a little bit more scientifically than that. So we had a cost offset. We're trying not to use the subsidy term. We had a cost offset until 2009. The challenge with the way that cost offset was done was it allowed that member jurisdiction to reduce, or to have us reduce, the fee that we charged to their residents. So for example, Fort Worth paid a $1.5 million cost offset, and we reduced the bill to their residents by $300 or whatever it was. And there were several cities that did that. It was a good revenue stream for us because it, was pretty much a direct payment. The challenge was the resident wasn't the one that benefited from that. It was whoever had the medical call inside that jurisdiction. So for example, we had a very small city that was providing a cost offset, a significant one per capita. So their residents were only getting billed about $1,000. But if their resident crashed their car or had their heart attack or, got a fall in the city of Fort Worth, that resident got the full boat bill because Fort Worth wasn't providing that cost offset. So calls in their city got the full rate. It was a nightmare. So we really convinced everybody just to stop doing it. When we were going through the economic downturn in 2008, 2009, we went to the cities and said, listen, we're going to raise our rate $100. Keep your money. Please don't buy down the bill. It's just a nightmare. And they pretty much all agreed to do that. So from 2010 to 2020, we were doing fine. We had a couple cities that still did the cost offset. You can see it here, but expenses were low, very high performance system. Revenue was pretty decent. Population was growing. Call volume was increasing. Pretty decent payer mix, as you saw earlier. So we did not do any rate increases for 10 years. So the rate that you see here that we published for 2018, 2019 was the same rate that we had done in 2010. So everything was fine. Everybody's happy. We were able to put money in the bank. No big deal. And then lo and behold, pandemic occurs. The big issue with pandemic, as you all know, is that costs skyrocketed and it became a huge issue. So one of the mitigation strategies was, okay, it's time to do a rate increase. Now, the problem was that we had done a rate increase in 10 years. Everybody else around us were doing rate increases, and we were way behind. We were only in the bottom quartile of the charges that everybody else was charging around us. So we had to then fight the political battle to say, hey, we need a fee increase and we'd like to increase it pretty dramatically because we think that will help increase revenue and keep the books balanced. And there you go. So it was going to be a significant challenge. We reminded our board and all of the member cities that we met with that we've been tracking this pretty closely, and wherever you see red is a bad thing. So in 2022, when we were halfway through our fiscal year, 7 months into our fiscal year, 10, I guess, technically, we were pretty much behind the 8 ball. We were $1.2 million in the hole. And what we were trying to do is to mitigate that. And in addition to cost reductions, we really had to figure out how to increase our revenue per service that we were providing. And as you can see, our revenue per transport was just below our cost per transport. So that was not good for long-term sustainability of the system. The last time that, and we never do these rate surveys, by the way, someone else does the rate surveys. We contribute the information from us to the rate survey people because we don't want to be accused of collusion, but we do get the results from the rate survey. And as you can see, some of these rates were all over the map. So if you look at Argyle Fire, they were underbilling. I know it doesn't cost them, $850. Their costs are much higher than that. Arlington, which was AMR, charging about $1,300, and this was back in 2017. You can see where we were, $1,485. So we were on the sort of higher end. In fact, we were the highest. We did convince many of these departments who were underbilling to bill at least the market rate because we knew that this was going to happen. So Fair Health, for those of you that don't know, is an independent nonprofit organization that tracks healthcare costs, both in-network, out-of-network, out-of-pocket, what's typically paid, et cetera, et cetera. And we used this extensively, and we used Fair Health in the case to make our rate change. So to give you an example, I just pulled this data from Colorado Springs. So your emergency advanced life support base rate in Colorado Springs for an out-of-network payment is typically $1,500. An in-network payment or price is typically $1,011, which really isn't terribly awful. It's a pretty decent rate. Now, you've got mileage tacked onto this. This is just the base rate, but this is a public database. And you can go, and when you get the handout, you can click on the link and you can put in the zip code that you're looking for, and it'll give you that region's ambulance rates by HCPCS code, including mileage and ALS1, ALS2, whatever you want, and specialty care transport. So you can see what the regional rates are for that service. And again, Asbel referred to that in part of his discussion. This information is now pretty transparent. The rates are out there. The costs are not, which is the bigger issue. So in making our case to increase our rate, to change our rate structure, we pulled the Fair Health for all of these area communities. Now you'll notice that there's not Fort Worth in here. And the reason that we didn't include Fort Worth is that when you queried the Fair Health data for zip codes in Fort Worth, oddly, they mirrored our current rates because we were the only provider. So the AO427 Fair Health query yielded $14.85. Well, that's because that's what we bill. That's what, blah, blah, blah. So we chose to not include that in the rates analysis because it would have been sort of, I don't know, just silly because that's the data that was coming back. But you'll note that these other areas, these other communities were averaging about $1,400, $1,474 for an ALS, BLS emergency, because they're all doing ALS, so there's really no BLS rate in here. ALS1, you can see the ALS2 rates. So we had proposed going to 1716 for the base and then 2200 for the deal. The other interesting thing that we found when we looked at the different rate structures is that many of the communities were charging for supplies. And interestingly, we had never charged for supplies because we were told always that, it's a fixed rate. It's, it's base rate, mileage, and maybe oxygen. Don't bill for supplies. Medicare doesn't pay for supplies. Well, that's true. Medicare doesn't pay for supplies, but Medicaid does. And a lot of the commercial insurers will pay for supplies. And there's a HCPCS code for that. So part of our rate change proposal was we established an ALS disposable rate and a BLS disposable rate built in to part of our rate structure. And you'd be surprised how many payers pay that supply charge, which builds up your collection per call. So this was the big deal for us. We had to meet with all the member cities. The authority board did approve the rate change, but they only approved it to raise it $100. But they did say, as part of that, keep raising the rate $100 every year until you get to be 50% of the Fair Health analysis. So just be in the 50% quartile when you do the analysis. So we do this every year. We did the rate change in 2020. So now this is the second time that we're going through this. So when we published our rates, the 2020-2021 fiscal year was $1,585. I thought it was interesting that our ALS non-emergency rate is still $911. It's been that since 2010, but they didn't give us permission to change that rate. But I can tell you that when we just recently did the analysis for 2022, and you'll notice that for the Fort Worth area, the ALS non-emergency rate still $911. We did get permission to go ahead and increase the rate because, again, we were far behind on the still far behind in the Fair Health analysis for the region outside of our service area, but still within that same region. So these are our current rates. They are about $300 more than they were a year and a half, 2 years ago, and we're going to keep increasing it every year. Now, I will share with you that when we were doing this, it was a pain in the ass. Because people had said, well, you never talked to us about a rate increase in the last decade. Well, of course, and we probably should have. We should have at least done some kind of rate increase. But the problem was that we were putting $1 million, $3 million, $4 million in the bank every year, and it would have been hard to justify doing a rate increase when we're already making a pretty decent amount of money to put into reserves. And as a governmental entity, you got to be careful with that. But we did communicate a lot. We did some for our member cities, for our board members, both one-on-one. We went to several city council meetings to explain to them what we were doing. Make sure that you research the fees in your area. Take the stakeholder temperature. Is there enough support to do the rate increase? Again, because we were very pragmatic and we gave them the data, we were very transparent about it. There wasn't a lot of concern. And we explained, doesn't impact Medicare patients, doesn't impact Medicaid patients, and arguably it doesn't impact the uninsured patients because they don't pay anyway. So it really doesn't matter. Never carry the coffin alone. Make sure you've got a lot of support so that when it happens, everybody knows that you've done that rate increase. Be prepared to answer. We talked about this morning, service levels costs, because we're having those discussions continually right now. How can we, make the system more efficient? How can we reduce costs? The 1 to 10 ratio, I'll mention, because I forgot to mention it earlier, is for every $10, actually almost really now, for every $100 that you increase your rate, you're going to collect $10 more per call. Sometimes less depending on the payer. But just because you're going to raise your rate $100 doesn't mean that your average revenue per transport is going to be $100 increase. It's going to be typically somewhere between maybe $1 and $10 depending on the payer. So that's how we did it. You'll get some of the links as we go through. We've got 1.5 minutes left. So anybody's got a quick question, happy to do it.
You see a couple on the screen now. Did you guys do an analysis to determine the impact of high deductible insurance plans?
Yeah, it's been a huge impact because it shifts a lot of your fees from commercial insurance payment to private pay. And our private pay collection rate is like 1.7%. So the more that we see the high deductible health plans, the more that, quote unquote, that payer mix gets shifted to the patient, and generally they don't pay, especially when the insurance company is telling them they don't have to pay because we're overcharging and our charges are outrageous. So the patient just doesn't pay, and we send them to collections, and there you go.
Out of curiosity, what do you get back from your collections just in general?
Our total gross, I think the last report that we got from the outside collection agency is we're collecting about 4.5%, if I remember correctly, on the calls that are turned over to collections. The collection agency keeps 1/3 of that. As Bill, if we use the solutions group, we do better than that, right?
Yeah. The next question was,
That's right, Matt. That's right.
where in your payer mix do you record TRICARE and VA patients?
They're under either the Medicare or commercial insurance. TRICARE, we lump into Medicare because they typically pay the way Medicare does. And what was the other payer? TRICARE and who else?
Okay. VA.
VA, yeah, VA actually pays, well, when they pay, we battle with them all the time, and almost once a year, we go to Granger's office, which is our local representative, with the latest report on the VA not paying us. They make a couple of phone calls, and lo and behold, we get a payment from the VA. VA is basically paying somewhere between Medicare and Medicaid rate. Thankfully for us, they're a very small percentage of our payer mix.
So, Matt, did you see a period of time, especially last year, because VA got so far behind in paying, we were starting to see full payment from the VA on our ambulance bills because they were so far behind. It was actually very shocking to us.
Yeah, we went before we engaged with Granger's office. We had gone 2.5 years without a VA payment. And they owed us over $2 million, $3 million, $2.5 million. And during an EMS on the Hill day, we hooked up with one of their health policy people and then followed up with the district representative here. And literally they carried the water. And I got to tell you, they were great. And within 4 months of the first documentation that we provided to Granger's office on how much the VA owed us, we got a $1.7 million payment.
All right, any other questions in the room? Looking. All right. Thank you, Matt. We'll see you tomorrow.
Thank you.